Beyond the Scale podcast. I'm your host, Dr. Spencer Nadolsky, and we brought back the amazing Dr. Danielle DonDiego.
Hi, guys.
Hey, so she actually, for anybody listening, she's been on the podcast multiple times. She's one of our, original clinicians, board certified in obesity medicine and family medicine. We went to school together.
Yeah, VCOM.
VCOM represent. And today we're going to be talking about stigma and bias in obesity. And this is coming off the heels of a position statement released by ACE, the endocrinologists. And actually my brother, Carl Nadolsky, endocrinologist and obesity specialist, was the lead author. So we'd been chatting about this a lot, and something that comes up often now amongst physicians and clinicians, because it really wasn't thought of before. And most people, think they're fine with their biases and their stigma and everything like that, but they actually don't even know that they even have some of these biases. So that's what we're going to talk about. So welcome, Dr. Danielle.
Hey, thank you.
Very good. All right. So you did a TikTok the other day. What did you talk about in that TikTok?
Yeah. So if you guys don't know, I like to do fun things on TikTok around obesity medicine, but I did a TikTok regarding what we call person-centered language. And this is something that I have implemented since becoming more aware of obesity as a disease and learning more about it. It's used in a few other communities too, but I think it's really pertinent in this community, where we say people have obesity or this patient with obesity rather than this obese patient. And so it's more, instead of describing it as what you are, it's something that you have. So it's not like a descriptor of you as a human. Yes. It's more so something that you just have as a disease. So
yes.
Yeah.
So yeah, for example, we, instead of saying this diabetic patient, this patient with diabetes, you are you and you have these conditions. You're not that thing. Somebody with cancer, they're not this cancerous patient.
Yeah.
It sounds ridiculous. That example is extreme and sounds ridiculous, but it's the same kind of analogy. So this person has obesity. Now, on the other hand, patients don't actually like that term obesity necessarily. Some don't mind, but even when you say you have obesity, that probably doesn't boil over well in the clinic. So there are studies looking at what words patients prefer. And actually there's a group of individuals out there who actually prefer the term fat. We would never, ever, I would never say to a patient, so you're fat.
Yeah, I feel like that word is off limits for me.
Never. But there are patients, there's a group of people out there that want to, they call it liberating that word. And I think that's fine. The patients they come in and tell me, yeah, doc, I'm fat. I know it. And I'm not going to say yes or anything like that. I'm just like, okay, well, let's just talk about it. So I think that's important. Patients, I don't know what you say, but I always talk about weight. We can talk about your weight and just leave it at that. Not whether it's excess weight or heavy weight. It's just talk about weight.
Yeah. And the way I look at it, when we are documenting and doing diagnosis codes and all the things on our end clinically, we have a whole language in medicine that we use to describe patients and to use for coverage. And what goes in our note is very different than how we speak, right?
Yes.
And so I like to reserve obesity for that as much as possible, unless the patient is already comfortable with that term, especially if it's a new patient. Because if they're just getting the guts to kind of come up and be like, I need help with my weight, and I start throwing out these terms, it can feel very overwhelming, right? So I do what you said, where I say, are you comfortable talking about your weight today? Oftentimes in reality, I let them bring it up. I rarely bring it up for patients.
Yeah.
Which I think is something that has been wrongly done in medical offices, is doctors are always bringing up a patient's weight. Oh, you need to lose weight, or we need to talk about this, when they're there for shoulder pain, right?
Yep.
So it's
always
triggering.
The cold. And actually, we've been in past conferences, we've been told well, you gotta get reimbursed. So once they come in for an upper respiratory infection, you talk about how their weight could be causing more upper respiratory infections. I'm like, this patient's miserable, coughing and sneezing and whatever. I'm not going to be like, hey, have you ever thought about losing weight? But I've heard other doctors say, yeah, no, that's the way you got to
Yeah.
bring it up. It's like, no, have them, hey, like, come back for a physical exam, and we can bring up things there. But I will say, now that you're an obesity specialist in that position, they're literally coming to you for it, so you don't even need to bring
Yeah.
it up.
Yeah,
I
I don't honestly ever bring it up. And I know when I was in like traditional primary care practice, there was a little bit of, I have this patient in the room for 15 minutes.
mm-hmm.
How much can I address? Because I probably won't see them for another 3, 6, 12 months sometimes. And
Yeah.
so I think sometimes that's where it comes from, but we also need to like unlearn that
Mm-hmm.
this is not something that's just like a checkbox that we need to talk about. We need to be very, very delicate with the situation and oftentimes let the patient bring it up. And so I think it needs to just be taught differently in actual practice, more so like in residency programs.
Yeah. And on the same token, not every little thing that the person comes into the office with is related to their weight.
Mm-hmm.
So the classic example, and this has unfortunately happened for anybody listening, I'm sure they've heard these stories. Somebody comes in with back pain. The doctor says, well, it's because of your weight. You got to lose weight. And the person has like a tumor in their back. And that this has happened. And it's like, oh my God, it's rare. Most causes of back pain aren't from some type of cancer. But, if in your mind this person comes in and they have obesity, and you don't have that stigma and bias training, you're just going to be like, oh, you just got to lose weight. I don't know what you want from me. But instead, they need to look at that person in front of them, which leads us to basically this position statement by the American Association of Clinical
Mm-hmm.
Endocrinologists, the ACE, and where they basically talk about, they actually get into the diagnosis of obesity, which this is a hot topic right now because, as you know, BMI. Let's first talk about BMI and the
Sure.
diagnosis of obesity, because this is part of the stigma that's here. So, what do you think about BMI, body mass index, for anybody listening?
If BMI, the way I like to describe it is a screening tool. And I believe this paper actually calls it a screening tool as
Mm-hmm.
well. It's not the end all be all. It it helps us to know what else to look for. Kind of gives me like another pathway to look for, but at the same time, it's just not all about this BMI number.
Mm-hmm.
There's so many other things. There's waist circumference, there's body fat percentage, there's, all the comorbidities. How active is this person? There's so many other things to look at that all factor into somebody's overall health. So BMI is not the end all be all in my book.
Yeah. For example, I have like my BMI puts me at an overweight category, but I've a decent amount of musculature that I don't have that much body fat. So if you just go by BMI, that type of thing could be missed. And
Mm-hmm.
they go into, yeah, waist circumference, but also even something called like staging the severity of somebody's obesity. So, for example, and we see this, we have patients who, they're metabolically and overall pretty healthy despite just having that BMI higher. And that might not be from muscle, like in my case, but they may have normal amount of muscle, but they're fit and relatively healthy. It's just strictly the number on the scale, and obviously the height. Kilograms per meter squared is how you do this calculation. And the reason they use it is, and we could go into the history, and there's a lot of history of why it was used in the first place, but in the end, it does do a decent job of putting people on a graph, like statistics, of like, hey, if you're in this range, you're going to be at risk for XYZ. But it's not perfect, and that's why we get into these more staging and looking where the adipose and weight is stored. So I think in the future we're going to get away from the BMI. It's
Mm-hmm.
just so ingrained that like insurance companies, medical diagnoses, obesity is still diagnosed that way, and even the trials are run that way. So for example, if we want to give somebody Wegovy, semaglutide, we have to have a BMI documented. We could diagnose some obesity in somebody who technically has a lower BMI because they have these complications of excess weight and they have low muscle, something called like sarcopenic obesity.
Mm-hmm.
And technically they have obesity and they may struggle. Um, but like to get the drug approved, you have to have a certain BMI criteria, which is 30 for anybody listening, or 27 plus one of these comorbidities. And that's not even taking into account ethnicity. So certain ethnicities, South Asians, have a lower threshold for when they start getting some of these weight related or adipose related disease states. So anyway, it's not going to happen anytime soon, but they do go into this in this paper.
Yeah, I feel like there will be a future where I don't know when, but there will be more coverage and more acceptability for treating people with sarcopenic obesity. I think that's going to happen, even though right now we have these BMI cutoffs. That's what they use. But yeah, are there people that are like a BMI of like 25, 26 that I feel like would probably benefit?
Mm-hmm.
Yeah, I mean, I think that that's something that might happen in the future. But the BMI being a screening tool gives us the vast majority of people that are truly struggling with obesity.
On the other side, there may be patients with like a 30 or 31 that are very healthy relatively, to where it, I don't know. This is something we could have a probably debate about, because I debate about it with my brother. These medicines are expensive, which I don't think they should be. I think the manufacturers could make these very
Yeah,
cheap, and then the PBMs, all that's a whole nother discussion. But these medicines are expensive. Insurances, nobody wants to pay for these drugs, and so there may be an argument for only using these drugs in those with a more severe clinical obesity. So someone, let's say someone has a 30 BMI. They qualify just based off of BMI, but that person's metabolically healthy. They have zero, there's absolutely no issues, but they qualify and they want the medicine because they want to lose some weight. Versus someone, let's say a 27 BMI, they technically qualify with a comorbidity. Let's say that person has type 2 diabetes, cardiovascular disease, sleep apnea, like all pretty much
yeah,
everything related, and they're more towards that severe side. That some people would argue, no, we shouldn't be giving it to those with just purely a 30 BMI, despite being healthy, and we should be trying to find those with the more severe clinical obesity. Anyway, it's an interesting concept. I don't think we're going to get anywhere near that anytime soon, because
agree.
I also don't think we should withhold it in that person that really wants it, who feels that they could have a better quality of life. Um, Despite
Agree.
being metabolically healthy. You know what I mean? And we see
Yeah,
it all the time. You can't even it's not even objective. Like, you can't objectively measure that person's. I mean, we could do certain little survey tools that they use for quality of life, but like there are things that aren't objectively biomarkers that we can test in somebody, but they'll say like my quality of life is just so much better now with the medicine.
yeah,
I,
yeah. And
it's
those are honestly some of the best messages that I receive as a doctor from patients after they've had treatment is one, they lose weight objectively, but two, how active they become. They have less pain. They're just happier, a lot of them. And those are the messages that I get, that it feels really good
mm-hmm. It
from my end.
does. It's very fulfilling for those listening. And so like one example is, someone didn't lose a ton of weight necessarily, but they lost enough to where they said, now I feel comfortable and pain free walking around Disney World with my grandkids. And it's like,
Hmm.
wow, like, maybe their blood sugars didn't improve, but now not so much pain, and just that joy of being able to finally go around Disney World. That's
Yeah.
you can't. How are you going to measure that? I don't.
And kind of on that note, and this goes a little bit into BMI, but somebody's height, I think this is an important point, is like, you can't necessarily look at someone on the outside and be like, they need this, they don't need this,
Mm-hmm.
right? Because you could have someone that's like 5 foot or 5'1", and like 10 pounds can make a world of difference for that
Mm-hmm.
person,
Yes.
metabolically, but also in how they feel in their quality of life. So,
Mm-hmm.
there's a lot of these headlines out there that's like, oh, people are using it just to get the last little bit of weight off. And it's like, well, if it puts them in like a higher risk category because their whole body composition. Like 10 pounds looks different on everybody, right? Or 20 pounds looks different on everybody. This is, I talk about this on TikTok a lot, of like just not judging someone based on how they look. I think this is happening with celebrities as well, is like people are getting very angry that people are losing weight. And it's like, well, maybe like, you don't know what they look like metabolically and from a doctor's perspective, right? So I think there's a lot of like judgment and stigma about people even using these medications for their weight and for obesity.
Yeah.
That's happening online right now.
Yeah. I think we're going to see a big paradigm shift. We're seeing it already, but more people are starting to accept that it's like, hey, these drugs aren't going anywhere unless there's some horrible side effect that we don't know about, but that should have already come out in the past 20 years since these drugs have basically been out. There's some big trials coming out that should show the signal that these are, I'm gonna bet that these are amazing drugs. And again, I don't make any money. I don't think you make any money from big
No.
but we've been around since these chronic obesity drugs have been coming out. So since we were in residency when Qsymia came out, that was like the first time they allowed phentermine to be long term, but they combined it with topiramate. So now with these newer, we call them second generation long-term chronic obesity medicines, it's just amazing. So I'm going to bet that these are going to be touted as amazing. It's only going to get better over time.
Yeah. And, it was, I believe, 2012 when ACE first recognized obesity as a disease, which was such a game changer because that put it on the radar for insurance companies to start covering things under, like, it got a diagnosis code, So something I talk to my patients a lot about, because there's a lot of frustration about coverage and all these things, right? We're watching change in real time in this community with this, this issue in medicine. And so it's going to be messy, it's going to be difficult. There's a lot of weight bias, weight stigma that will stick around, and it's going to take time, but it's only been in the last like 10 years that this has even evolved, and now we have a whole board certification, and now we have all these medications and more coming out. So it is only going to get better.
Yeah. 10 years from now, I don't know what it's going to look like. There's going to be some ridiculous drugs. So
yeah.
Okay. So moving along with it. So the BMI, they talk about how that shouldn't be the only thing that helps with diagnosis of obesity. I think that's great. They do talk about, though, like they go into the definitions of bias, stigma, and all these things. So weight bias is a negative ideology associated with excess weight. Weight stigmas is the thoughts and acts of discrimination towards the individuals due to their weight and size result of weight bias. Internalized weight bias, though, is when a person applies those negative weight stereotypes or biases to themselves and engage in self-devaluation. Then there's implicit weight bias, is an unconscious bias towards a person who has obesity, beliefs or attitudes outside of an individual's awareness and control. Then lastly, there's explicit weight bias, which is the awareness of bias and intentionally behaving negatively towards a person who has obesity. So maybe we can unfold that a little bit, because basically what we see is probably we see explicit. We're in this kind of the social media world. We see they're just people.
Social media is rough.
Social media is rough. I don't care if it's TikTok or YouTube or Instagram. It doesn't matter where you are, Facebook, whatever. There are a lot of people with straight up explicit weight biases, and they don't even care. They'll just say it, and these are just awful.
Yeah, they've made like whole brands based on this. It's rough out there. Yes. I tell my patients, put blinders on when you go on the internet.
Yeah. Then there's the implicit. These are things that, so it's not conscious for the individual. And we see this a lot with like clinicians who they think they're doing a good job and they think they know what they're doing, but it's just this implicit. They're not aware of it. It's not conscious, but there are biases against that person who has obesity. And that's really dangerous, because that's where you get misdiagnoses. That's where you miss things. You put these blinders on. You don't even realize that you're doing it. So these are just helping people become aware of these and helping them improve is important. I think the one thing, though, is internalized weight bias. This is kind of a different concept that they talk about how you can screen for this, but all of these things actually can worsen patient outcomes.
Yeah.
And if you're a clinician, especially, you want the best for your patients, no matter what, not despite their weight or anything like that. So if you have these biases, you're actually worsening outcomes in your patients. But if you're
Yeah.
a patient and you have this internalized weight bias, that can also lead to poor outcomes. And this is a harder thing. You can screen for it. We're going to try to figure this out, probably do some things within Sequence. But I don't know how, like, you got to screen for it and then somehow do cognitive behavioral therapy, what they discuss in here, to try to reduce that internalized weight bias against yourself. That's kind of
Yeah.
tough.
I think another thing I talk about a lot is why having a counselor or therapist that is well versed in this is a really important adjunct to treatment of obesity. I know it's not accessible to everybody, which is another issue, but in a perfect world, I would want all my patients to have somebody that they can talk to sort through these things, because that internalized weight bias can really cause self-harm. And so basically, in a perfect world, I would want all of my patients to be able to see a counselor, see a therapist to
Yeah.
discuss, their journey with weight loss and obesity. Because most of our patients, it's been pretty lifelong or been pretty chronic.
Okay.
And so, yeah.
Okay. So yeah, with all that, at Sequence, we are really trying to make sure we are careful with the way our lessons are worded, the way our intake is. We're constantly looking at these things. We don't want to worsen internalized weight biases for our patients. We don't want to seem stigmatizing at all. So a lot of thought and care has been put into our program, and even with like training of our clinicians, trying to make sure that, hey, there could be some of these implicit weight biases that we want to look for and help then bring awareness to these. Because again, if it's implicit, you don't even know that it's there. It's subconscious. Any closing thoughts?
I think for patients out there that are thinking about seeking treatment, you need to feel comfortable. No matter what it is you're going to your doctor for, you need to feel comfortable. And you deserve to have somebody that understands what you're dealing with on some level. So if you're in a place where you feel uncomfortable, that's why I think Joint Sequence has been so awesome, because we do provide care in all 50 states. And we do have doctors that, we're always looking out for this, and we're always changing our platform to keep up with what makes our patients feel the most comfortable. And, because they're worthy of that. So find a clinician that you're comfortable with, that you can speak to about obesity openly. And we're there for you guys.
Very good. Thanks. So if this resonated with you, make sure you share and give us a nice little review. Share it with a family or friend, family member or friend who may be thinking about seeking obesity treatment. And again, if you have a clinician, that's great. Your PCP, that's awesome. But if you're like, hey, I don't feel comfortable. I want somebody who's going to listen to me and have, understand the stigmas and biases. Seek us out at joinsequence.com. Thanks for listening. Thanks for coming on, Dr. Danielle.
Thanks, guys.